Next, Eric Michelson and Dr. Vera Bittner, Professor of Medicine and Director of the Cardiac Rehabilitation Program and Section Head of Preventive Cardiology at the University of Alabama in Birmingham, discuss improving metabolic risk factors through lifestyle changes.
Vera, welcome.
Thank you very much for having me.
Could you give us a little background on this topic from your perspective?
Yeah, I mean, everybody knows that cardiovascular disease remains, if not maybe the most important cause of morbidity or mortality, but clearly one of the most important causes of morbidity and mortality, not just in the US, but worldwide. And metabolic risk, which is intimately related to lifestyle, plays a very large part in this epidemic. And so there's an increasing emphasis trying to modify that.
What are some of the elements of metabolic risk?
Metabolic risk relates to the increasing prevalence of obesity, to physical inactivity, to a poor diet, which then first leads to a pre-diabetic state and ultimately to diabetes. And all of us know how much of an impact diabetes has on subsequent cardiovascular outcomes.
Well, these are virtually epidemic problems in the United States. This must be quite a challenge for you running a preventive cardiology program.
Especially since I practice in the South. And if you look at these obesity maps that the CDC has, we're kind of the epicenter of, the metabolic syndrome and of, obesity. But it's not just the U.S., it's really a global issue.
And of course, these things then feed into the manifestations of these metabolic risk factors, actually causing some risk and diabetes, hypertension, etc., correct?
Correct. And, what is increasingly recognized is that medication management can only go so far. There's a very nice paper from Germany where they looked at favorable lifestyle characteristics among diabetics and related that to outcome. And it turned out that the more favorable lifestyle characteristics an individual had, the better the prognosis was, even though all of them had underlying diabetes. So clearly, lifestyle is something that is worth intervening on because it presumably is related to prognosis.
As a focus of this interview, I'd like you to give us a perspective on a very important NIH-sponsored trial called Look Ahead, which does address this issue.
Yes, it's a randomized controlled trial in a bit over 5,000 individuals with type 2 diabetes who are being managed pharmacologically by their own personal physicians, but are randomized to an education intervention and a very intensive lifestyle intervention. And this is a unique trial in that it doesn't just look at intermediary outcomes, but over the long term looks at morbidity, mortality endpoints.
What did this patient population look like at baseline?
Age range 45 to 75, selected for being obese, very high prevalence of hypertension, dyslipidemia, and other risk factors. And so in many ways, a typical diabetes population, with the exception that individuals with significant renal disease or individuals who could not safely pass a treadmill test were excluded because the question was whether the lifestyle intervention would be safe.
And just so we might relate this to our own practices, what type of hemoglobin A1Cs, LDL, weights, for example, BMIs?
The BMI was quite high. It was on average 36. The A1C, LDL, and blood pressure numbers looked quite good. So the mean in the trial was close to the goals. 7.3% for the A1C, systolic blood pressure over 129, LDL cholesterol of 112. But when you look at it the other way, how many of these patients were actually at the American Diabetes Association goals? Then the picture looks much less rosy because it was less than 50% for the A1C and lipid parameter and only 37% for the blood pressure parameter. And all three of them were only at goal in 10% of the population.
Yeah, that's not surprising, is it? The disappointing but not surprising. And the patients were already on medications at baseline?
A lot of them were. The prevalence of medications is not as high as what you would think in the current era it should be. But remember that this trial was started in 2001, and so it doesn't quite live up to the standards of medication that you would now see in 2012.
In this trial, are there targets for any one of the measures or intermediary surrogates such as hemoglobin A1C or weight or BMI or blood pressure, for example, or LDL?
The weight is a target, and so is physical activity level. But the other measures that you mentioned, the A1C, LDL, etc., they're actually outcomes of the intervention. So they don't target specific goals for those.
Now, you said the trial began in 2001. Where are we?
Well, they're actually fairly close to getting to the end of the trial. They're trying to see the last patient at the end of 2014. And so we will hopefully have the morbidity mortality results by the middle of the following year.
And what are the outcomes? Are they cardiovascular outcomes?
Yeah, the primary endpoint is a combination of fatal and non-fatal cardiovascular disease and including hospitalized angina. And then there are a variety of secondary endpoints.
And what type of event rates were expected in this trial?
That's a very interesting part of it. So originally the investigators expected an event rate in the control group of over 3% annually. And that was based on existing epidemiologic data. And then they found out about 3 years into the trial that the actual event rate trial-wide was only 0.7%. And that led to a lengthening of the follow-up period and the inclusion of the hospitalized angina in the endpoint.
Do you think that may have been because of the advent of more aggressive medications, statin or other medications? Do you think there's other factors in play here?
The treatment probably played some role, but there was a very interesting paper in the AHA Open Access journal recently that looked at mortality rates across trials among diabetic populations. And it turns out that there's a very wide variation. It was 29-fold between the lowest and the highest trial. And it turns out that diabetic renal disease is probably the most important driver of this outcome. And I told you earlier that they excluded those folks up front, and so that probably drove the lower event rate.
How aggressive is the aggressive treatment in that arm of this trial?
Very aggressive intervention in terms of frequency, but not necessarily in terms of the intervention itself. So when we're talking about the physical activity intervention, we're not trying to get these folks to run marathons or things like that. I mean, it's basically following the overall physical activity recommendations of moderate exercise on most days of the week. The target is an over 7% weight loss with appropriate dietary caloric restriction depending on what the beginning weight is. The reason why I said is that it's intensive in terms of frequency is because it's a combination of group meetings and individual counseling that goes from very, very intensive initially to moderately intensive out to 4 years, and then still relatively frequent contact with the investigators after that. So something that's a little harder to do, I think, in a practice setting.
Does the NIH trial provide funding to support all of this activity, which would otherwise be quite prohibitively expensive for most of us to assure good adherence and compliance?
That is all covered within the trial. There's also some contribution from industry to make this, financially feasible. But the trial was designed to limit barriers to participation, and that even includes things like arranging for childcare or providing transportation costs, things like that would be difficult to do in a typical practice setting.
One imagines then that if this trial is positive, it might be very, very helpful for an expert such as yourself to get support for reimbursement for preventive cardiology programs to be more intensive.
Well, all have good evidence, I think, that individuals with multiple risk factors, and diabetics certainly fall into that category, would respond to a lifestyle intervention the day before the event as they would the day after the event. And so it's always very disconcerting to us that we can do cardiac rehabilitation after the myocardial infarction, but not in the individual who has very high risk or multiple risk factors who we would like to catch years before that, hoping to prevent that event. And maybe data from Look Ahead will move payers kind of in that general direction.
I find it quite remarkable that they've been conducting, and yourself, this trial now will be 13 and a half to 14 years completed. We're almost there. I think the results will be tremendously informative. Thank you for sharing this expert's view of this trial with us, and I'm sure the audience is looking ahead to the results of Look Ahead.
Yeah, thank you very much, because I think a trial like that could have a huge public health impact if translated to daily clinical practice.
And that's the goal. Thank you very much.
Thank you.